Good afternoon. This is Dr. Kyle Infield with the Society of Critical Care Medicine's iCritical Care. Today, I'm joined by Dr. Walid Al-Hazani and Dr. Mitchell Levy, who are going to be talking to us about the new COVID-19 guidelines. We're all, like you, preparing, planning, and caring for critically ill patients with COVID-19, but we thought it would be a good time to take out of our day to discuss how those guidelines were developed, what surprises came out of those guidelines, and what information we still need to know. I'm going to ask Dr. Levy and Dr. Al-Hazani to introduce themselves and also reveal if they have any disclosures that the audience should be aware of. Dr. Levy?
Hi, I'm Mitchell Levy. I'm the Chief of Pulmonary, Critical Care, and Sleep Medicine at the Warren Albert School at Brown University, and I'm the Medical Director of the Medical Intensive Care Unit at Rhode Island Hospital, and I'm a former president of the Society of Critical Care Medicine.
Dr. Al-Hazani?
Hi, my name is Walid Al-Hazani. I'm an associate professor of medicine and health research methodology at McMaster University in Canada. I am the methods chair on the Surviving Sepsis campaign and the Surviving Sepsis campaign COVID-19 guidelines. I'm also a intensivist and a gastroenterologist by specialty.
Thank you all both for taking the time out today. I'd like to start with you, Dr. Al-Hazani, and talking about what was the process used for picking the core questions for this new COVID-19 guideline, and what process was used to review the literature and to get these guidelines out?
That's a great question. So given that COVID-19 is relatively a new and rapidly spreading illness, we felt the urge to issue some guidance or help issue some guidance to clinicians and especially those dealing with acutely or critically ill patients in the intensive care unit. One could argue that if there is enough evidence, and high quality evidence, guidelines might be less important. Others may say, well, we need guidance when there is lots of gray area and uncertainty. Some guidance might be helpful. Now, how did we choose the question? We decided with the chairs and myself about the scope of the guideline. We thought to focus on four main themes of the guideline that is related to the management of critically ill patients with COVID-19. The first was on infection control and testing. So it has to do mostly with healthcare workers and keeping their, ensuring their safety and addressing the relevant recommendations on this section. We also focused on supportive care, which was divided into two main domains. One is ventilatory support, given the fact that most of those patients who end up in the ICU end up being mechanical ventilation or some sort of life support. The next section was on hemodynamics support as well, given the fact that also one of the other reasons for admission to the intensive care unit is hypotension and shock. And the last part of the guideline, or the last theme of the guideline, was focused on therapy or therapeutic strategy that does not fit in any of the first few sections that I've mentioned, and are related to directly managing the disease itself, or therapies directed against the virus, or to support patients like corticosteroids and other interventions. So that was the first step, is deciding what is the scope, what are the areas we want to address. And then discussion with experts. So we were lucky to have multiple experts, over 35 experts from at least 12 countries around the world. Many of those experts have treated patients with COVID-19 and were involved in the active management and also the scientific aspect related to this illness. So we assigned panel members to each of those groups based on expertise. And we said, okay, what are the most important questions that clinicians need guidance for. And we addressed those questions based on discussion and consensus. Another approach we used, we also looked at questions that were addressed in the previous Surviving Sepsis campaign guidelines, specifically related to hemodynamic support. And we said which of those recommendations or questions that would be relevant to the management of those patients. So that saved us some time in terms of defining which questions. For the last group on therapy, we asked the experts in the field as well, what are the therapeutic options that are important and need to be addressed quickly in this guideline. And then we came up with a list and formulated the questions. And this was in a nutshell, the process of selecting the topics and the questions related to the recommendations.
That was great. You did a great job of summarizing how you got to those questions. As a member and as a reader, I was fairly impressed at how fast you all were able to develop this publication, especially with 35 experts in the field coming together to answer those questions. As you reviewed the literature, were there any major surprises about where the recommendations led, or do you feel like that as you were reviewing this, what you found is that the guidelines pointed us to continue to practice really exceptional critical care? Were there any, I guess, surprises specific to COVID-19 that you didn't anticipate?
Okay, it's another great question. I would like to answer this question in two different parts. So the first part that's related to your question is how did we design or plan, looking for literature, conducting the systematic reviews. So the way we did it, we said, this is a relatively new illness. We expect that there isn't much out there other than descriptive papers, and that would help put things into context. So the way we did it, we said, okay, we'll have to have two streams. One stream is to look for COVID-19 specific scientific articles. The other stream is to look for indirect evidence that could be applicable or that we could extrapolate from to help manage the general critical, care support for those patients. So that's what we did. We conducted what's known as rapid reviews. We had a big team of systematic, or a big team of called the systematic review team, with people who are have a lot of expertise in conducting systematic reviews, and we conducted rapid reviews and tried to collate the evidence quickly. We actually did that in the course of 14 to 18 days, give or take. So that's the first part of the question. We did actually have a pre-planned process that, and we also followed, pragmatically followed an algorithm that we developed in how to decide which indirect evidence is applicable and which is not, because there are extremes of, indirectness and applicability of the evidence to this context, and there's a lot of judgments that need to be made, and this judgment is also based on the clinical expertise of those members who have managed a large volume of those patients, and also what have the literature, described the course of the disease was. So it was an organized but also pragmatic in the same time. Generally speaking, this process of guideline development, and Dr. Levy, been leading the guidelines for many, many years. The process takes anywhere between 1.5 years to 2 years to develop, a large guideline based on, sound systematic reviews. And we tried to use a pragmatic approach and squeeze that in so we can produce an evidence-based but also timely guideline for clinicians. So that's the first aspect. The second aspect, have we find any surprises? Well, it's a surprise, but it's not. There wasn't much directly related to COVID-19, but we also found out that there are many, many RCTs or clinical trials that are ongoing, which made us also design the guideline to be a living guideline, meaning that we will be updating recommendations if need be. If new evidence comes out and says, well, it seems that this intervention works or doesn't work, or something that would trigger us to change a recommendation, the panel will assemble quickly and look at it and determine if a recommendation needs to be changed or not, or if a new intervention that we have not addressed in our guideline comes out that requires recommendation. Same story will happen. We'll assemble the team and summarize the evidence and present it to the panel and issue recommendations. So I guess this is one of the way that I see this guideline would be useful to clinician, because the accumulating evidence is rapidly getting published, and we'll have to keep up with it to make sure that we produce something useful to and up to date to the frontline clinicians.
Thanks. I have been impressed with the number of publications coming out directly related to COVID-19, and it's good to know that there's a plan for incorporating new high-quality evidence as it comes forward, because the evidence that's coming out seems to range from sort of observational data to stronger interventional data. So that's good to know that you guys will be updating it. Yes, Dr. Levy, I know that you and I spoke right before we started about the planning and preparations that you're undergoing in your health system. Are there questions that you wish could have been answered that you're wrestling with now as you develop your plans, and that we could start thinking about how to answer with future research trials?
Yeah, that's a great question, Kyle. I think that the two most important questions that I think every healthcare system is dealing with is the PPE question, the personal protective equipment, and the ongoing trials for therapeutic interventions. So, and as we know, in my institution, for instance, guidelines are changing very quickly. So we originally, in my institution, went with a hyper-protective and over-cautious approach, where we were recommending N95 respirators for any interaction with COVID-19 patients, whether they were aerosol generating or not. And very quickly, as we realized that we were going to run short on N95s, we then became consistent with the CDC guidelines and our SSC guidelines, which is N95 respirators and face shields for aerosol generating procedures in COVID-19 patients. But apart from that, a simple surgical mask with a full face shield is adequate. And that's a moving target. And it certainly is creating a lot of anxiety amongst caregivers in my institution and other institutions, where they're facing either rapidly changing, I should say, guidelines for what PPE looks like, and even worse, shortages of the PPE that they need. So that's very that's a real source of anxiety for a lot of caregivers on the front line. And the other issue of questions that really need to be addressed still is the therapeutic trials. We, as Waleed said, one of the things we had to adjust to, I should say, that's the real difference between these COVID-19 guidelines as opposed to the Surviving Sepsis Campaign sepsis guidelines, is the absolute lack of evidence. Everything is small cohorts, tiny group studies, and of course, because of the general concern and the desire to see anything that works, we're seeing publications appear in fairly major journals that are very small numbered trials. People are seeing studies, prospective cohort trials appear with 20 patients, 30 patients. So that makes it very difficult to really assess the evidence properly. And I think what needs to be done, and is happening in many areas, are good randomized controlled trials enrolling as many COVID-19 patients as possible, and so that we can make some sense of what the interventions are that actually work in these patients.
Yeah, I couldn't agree more on both areas. I think the PPE challenge is one that we all face, not only the changing recommendations, but the reactions that we have to social media posts and then additions of shortages. And I know that all of us have been wrestling with that within each of our institutions. I didn't prep you all for this question, so it's slightly unfair, but I have wondered, how do we as an SCCM community share practices that we have developed that could benefit other locations. And I'll highlight one from our institution. We had contacts with Columbia, and they had figured out a way to bring their ventilator monitors outside of the room and still be able to control the ventilator safely using essentially an Ethernet cable cord and keep the room's negative pressure. And that's allowed our respiratory therapists to decrease their PPE utilization and exposure to the patients while still providing great care. And I've been challenged to figure out ways that how do we share that with our peers so that we can all learn together, because it's going to be hard for it seems unfortunate that we each have to learn these as N of 1 studies with each institution. I wondered if you all could reflect briefly on that.
Well, that's what the idea of the living guidelines are. I think that, as Walid said, we're putting in place a process whereby we can incorporate the most up-to-date literature very rapidly on whether it's the Surviving Sepsis Campaign guidelines or not. And I think on the Surviving Sepsis Campaign website, I think that in addition to new literature, I think we'll also have an area where we'll list these best practice models, which we already do to a certain extent in the guidelines.
That's great. I know that one of the questions that has come to me from other SCCM members in our community is what messages can we be taking back to our hospital leadership now if we're not already in a planning phase, and what steps should we advocate for at our local hospitals if they have not started planning? What processes should we be putting in place now, recognizing that we're probably already behind where we should be, but as we also think towards the future for our plans?
So I think I can't imagine that that there's an area where people aren't planning already. And I think that when I've talked to my colleagues, everybody understands the need to develop a surge plan for maximizing the number of ventilators and then going even beyond that in your institution, and planning on how you will stretch your staff far enough to be able to cover. In my hospital, we're trying to plan for 200 ventilated cases in a 750 bed hospital. So I think that the surge planning is probably the most important thing that all of us as critical care colleagues are struggling with right now. Surge planning for the number of ventilators, for the amount of PPE, for where we're going to put these patients, and who's going to take care of them.
Dr. Al-Hazzani, as we all start to grapple with this, in the not too distant future, though it seems distant today, we'll be in a situation where we will hopefully get past the surge, but COVID-19 patients will still be sort of part of our daily routine. What do you think that new future state is going to look like for us as critical care providers as we think about our ICUs, 6-9 months from now?
Oh, that's a tough question. It's hard to give a prediction. It seems to be going to be a little bit different than what happened with SARS. We had a peak, and then we start to see the sporadic cases, ongoing, but nothing with large volumes. I am hoping that it will be, this way, but I think there will be a pre-COVID, a post-COVID era. Well, many things would change in the critical care daily practice. People will probably plan, ahead of time and plan properly. There will be more exposure to, general practitioners to acute care, so they are ready when things like this happen. There will be more resources, but I also think that the threshold for goals of care, end of life discussion, are probably going to change down the road, and even from a safety perspective and health care workers, I would suspect they'll be more conscious about self-protection, which I have to admit I'm one of those who used to be very sloppy when it comes to these things, and now after what's happening now, people are like more conscious about these things. Now, how is it going to look in 9 months from now? Is it going to be, I think only time can tell. And but I'm hoping it's going to be similar to SARS, where there's a rapid peak and things slow down, maybe a second wave, and then you'll start to see sporadic cases as people develop immunity to the disease. But again, I could be completely wrong. It's just my own personal guess.
I think we all have our own personal guess, but I think that's as good a one as any. I know both of you guys have an immense load on your plate right now, so I want to take the time to say thank you for taking the time to share these thoughts. For the listener, if you've not had a chance to read the COVID-19 Surviving Sepsis Guidelines, they're a wonderful resource that have helped a lot of institutions plan for COVID-19, and I commend them to your reading list today. Thank you very much, and I will just end with Dr. Levy as a person who's done this before. Any final thoughts to share with the listeners today?
Well, I think the most important thing is just to be good leaders, whether physician, nurses, respiratory therapists, or any allied healthcare worker. That this is the time for us to rise to the occasion, to be a steadying influence, and to really communicate to the people we work with that we'll get through this together, and that by working together and being willing to step up and do the right thing, we'll come out of this stronger and closer.
Thank you very much for that. Have a great day and good luck to you both.
Kyle Enfield, MD. Kyle Enfield, MD is an associate professor of medicine in the Division of Pulmonary and Critical Care at the University of Virginia. He received his undergraduate degree from the University of Oklahoma. He received his joint medical and master's degrees in epidemiology at the University of Oklahoma Health Science Center and went on to complete his residency and fellowship at the University of Virginia. In July of 2013, Dr. Enfield was appointed as the medical director of the Medical Intensive Care Unit at the University of Virginia. From 2009 through July 2016, he was the assistant hospital epidemiologist there, and he remains the co-medical director of the Special Pathogens Unit. Dr. Enfield's clinical interests are in critical care medicine and transport of critically ill patients. His academic interests are the epidemiology and prevention of healthcare-associated conditions, including multi-drug-resistant organisms acquisition and healthcare-associated infections. Join or renew your membership with SCCM, the only multi-professional society dedicated exclusively to the advancement of critical care. Contact a customer service representative at 847-827-6888 or visit sccm.org/membership for more information. The iCritical Care podcast is the copyrighted material of the Society of Critical Care Medicine, and all rights are reserved. Statements of fact and opinion expressed in this podcast are those of authors and participants and do not imply an opinion or endorsement on the part of the Society of Critical Care Medicine, its officers, volunteers, or members, or that of the podcast commercial supporter.